The teaching point on that case was that I think a few of you could have gone down the tubes on the ACL, right? There weren't a lot of bone changes. There was not a lot of tibial translation. The ACL looked pretty straight. You might have assumed the celery stalk was intact, and that would have been a mistake. Okay, you didn't come here to see fractures, that's for sure. You came here to see a lot more. Evaluate for medial tibial plateau fracture, possible hyperextension injury. Evaluate status of ACL and menisci. Age, 18. Quick look at the axial projection. We've got more than one. I'll stick with the high-resolution one. We've got an object in a moderate size, grade 3 out of 4 fusion. How do I grade them? Subjectively. But I do allow 1 by 1 centimeter of fluid accumulated in the anterior knee, the base of the ACL. I consider that normal lubricant. If I have an effusion that distends the front of the knee, it's a class 3. If it distends the entire knee in its entirety, diffusely, it's a class 4. Somewhere in between is a 2. There's an object, anterior and medial. Is it blood? Is it cartilage? Is it bone? We don't know, but we better know. The MPFL, a little fibrillated, intact. Our tibial collateral ligament, fat. Now they're all fat, but this one's a little fat and a little gray. How about our posterolateral corner and our posterior capsule? There's our capsule. It is not continuous. Looks better here. Looks a lot worse here. Let's check out our semimembranosus. There's some swelling around it. Sort of tough to actually see it attached to the bone. I'm a little concerned about it. We'll come back to it, though, in another projection. Our tib-fib ligaments are swollen. That's interesting, especially anteriorly. Here's our biceps femoris, which has a bifid insertion laterally, an anterior and a posterior component to it. What about our fibular collateral ligament? There's the origin. There's the FCL. It looks a little irregular as we come down. How about our popliteus tendon? There's some swelling in the popliteus hiatus. How about our ACL? Looks pretty straight. How about our PCL? It looks a little funny. What's that? It looks like the letter L. That should not be there. So perhaps we have a PCL problem. All of this cicatrized swelling and cob-like irregularity related to extravasation of blood and fluid from the torn joint capsule. Let's go. The next image up is the coronal. Why? Because it's there. And I'm busy. And I got to get home. And there's disease everywhere, so I don't really care which projection I choose at this point. The coronal also gives me a pretty good, quick inspection of all the menisci. In fact, I like it the best, even better than the sagittal. And I've identified a menisco ligamentous tear right there. So the medial meniscus root ligament is torn. You could tear the ligament, or you could tear the root next to the ligament, or you could tear the posterior horn. This time we have torn, there's the ligament, there's the meniscus, they're not connected. On the other side, there's the ligament, there's the meniscus. They are connected. Okay, that's a subtle little finding, but by itself it could be relevant. Root tears are extremely common, but sometimes in active young individuals, if they occur and they're left unchecked or the patient is not rested, then the meniscus starts to gradually spit out and extrude and become unstable over time, and they end up with secondary disease. In this case, it's a pimple on a donkey's rear end compared to what we have. Let's look at our MCL, since we're in the neighborhood. Superficially, swollen. Tibial collateral, swollen. Meniscofemoral attachment, present, but swollen. Meniscotibial attachment, coronary ligament, present, a little wavy. ACL, nice and straight. ACL distal attachment, straight. Swollen, but straight. PCL, it's vanishing. We look inside the PCL in the coronal projection to diagnose a PCL tear, because the PCL is often swathed in a very thick sheath. And if that sheath is inflamed, the PCL and the sagittal may look very gray. So you go to the coronal and you look inside the circle. So here's the circle. And we should have black inside the circle. We don't. That PCL is going to be gone. Now, one of the nastier injuries that goes unrecognized is a PCL tear with a posteromedial or lateral corner tear, because PCLs are not repaired. But a PCL with a corner injury, repaired. So you better not miss that. Let's check out our fibular collateral ligament. I thought our fibular collateral ligament was diseased axially. I was wrong. It's a little swollen, but it's present. There's a tremendous amount of swelling next to it. How about our popliteus? I thought it was a little swollen at the origin. It is, but it's still there. I think it's time to look at the sagittal projection. Let's put them both up together. Let's go right to our PCL. So our PCL is torn from the femoral end. Now, femoral end PCL tears are usually more heinous and more ominous than tibial N1s. If you have a tibial N1, the only time you operate on it is if it has taken a piece of bone with it and you come at it from the back and you put a screw in it. Otherwise, they're left alone. So this is a nasty sign that more is going on. There is a high-grade microtrabecular fracture. Is there a kissing lesion in the tibia? No. So perhaps with the leg slightly flexed, the patient took blunt trauma from the front and drove the tibia backwards as the mechanism of injury, impaction. Let's keep looking, shall we? Let's go to the posterolateral corner first. There is our popliteus tendon. It's a little swollen proximally. We were right. It's a little wavy distally. And the popliteofibular ligament is torn. Mermaid sign. There's the tail of the mermaid. Yeah, a little bit of it is attached, but most of it's torn. There are some little fibrillary particles or bits of the arcuate. It's torn. So we have a posterolateral corner tear. However, the popliteal meniscal fascicles are still present. There's a nice tight relationship between the popliteus and the posterolateral meniscus. Maybe that one's a little wavy, a little stretched out, I admit it. The upper one nice and straight. So maybe a sprain on the lower fascicle set. So posterolateral corner injury with a mermaid sign. We do not have a fibellofibular ligament. There's an inverse relationship between the size of the fibellofibular ligament and the arcuate ligament, which is right here and torn. And we can infer its tear by some of these wavy lines and the presence of swelling in the arcuate fossa. Let's go over to the posteromedial corner, because this case looked initially like an innocuous fracture and PCL tear, which would be non-surgical. Wow. Okay, so here's our semimembranosus. We weren't that impressed with the semimembranosus axially, but we did say the tissues around it were a bit swollen, like here and here and here. This is a T2, and it certainly is swollen. But what about the rest of the corner? The capsular component of the semimembranosus corner. In other words, this structure gives rise to fibers to this capsule. That is torn. So the oblique popliteal ligament component of the posteromedial corner is ruptured. The meniscocapsular anchor and block stop mechanism is ruptured. The center of the oblique popliteal ligament is ruptured. And as we go over to the lateral side, it's not surprising that the entire posterior capsule, the oblique popliteal ligament, tears all the way from side to side. So we have a posterolateral corner injury and a posteromedial corner injury. Fortunately, a large component of the semimembranosus on the posterior semitendinous tubercle remains intact. This anterior component is the pars reflexa component of the semimembranosus. It's intact. Let's see if we can see the distal component. There it is. There's the distal component of the semimembranosus. It's intact. Here's more of that capsular rupture. Let's look at the T1 and blow it up. You'll see quite a bit of blood in the neighborhood. The posteromedial corner far more impressive on the water-weighted image than on the fat-weighted image, where everything is just simply gray. Look at all the capsular stripping and detachment seen in the posteromedial corner and the meniscocapsular separation. Let's talk about the posteromedial corner for a minute. There's a beautiful paper written on this in Radiographics in 2015. So the posteromedial corner is the neglected corner, and when it is neglected, we discussed how it can lead to stress on other structures, specifically the posteromedial meniscus. If you've got a PCL tear and you miss a posteromedial corner injury, you have probably deprived the patient of a surgery that they need. There are 5 major components of the PMC. We've got the semimembranosus and its expansions, the oblique popliteal ligament component, so the semimembranosus would be the main tendon. You've seen the oblique popliteal component, which is the posterior capsule. Then you've seen the posterior oblique ligament, which you see best in the coronal projection, associated with the superficial MCL, and I'll try and point them out to you as we go through cases throughout the day. You've got the posteromedial joint capsule, which was injured in this patient. There was meniscocapsular separation. And then you've got the posterior horn of the medial meniscus, which is considered part of the corner. And if we go back to the case for a minute, which I will do, I want to bring the lights down just a little bit so they can see this better. But you've got the meniscocapsular area filled with blood. And then as you look at the meniscus, the edge of the meniscus is abnormal right there. So the edge of the meniscus is also torn. So the capsule is torn. The oblique popliteal component is torn. How about the POL component in this case? The POL component is going to travel with the superficial MCL. It can be tough to see. See if we can pick it up. Usually in the back you'll see it, and there it is. There's the POL component right here. It's this thin linear structure. It's actually intact. Let's flop back over to our slides. This is a diagram showing you the semimembranosus expansion, and this one's seen in the oblique projection. Here's the semimembranosus muscle. Here's the tendon, and here are the individual arms. And I've got them labeled for you. You've got a capsular arm, an extension to the OPL, which was torn in this case, the direct arm, which you almost never see, the anterior tibial arm, which is known as the pars reflexa, which I have shown you. There's an inferior popliteal arm, which I will show you a little bit later on, and there is a distal inferior arm, which you can see, and I will show you a little bit later on. I think it's easier to appreciate in the sagittal projection. Here are the semimembranosus expansions again, seen in the sagittal projection, and I want to point out the posterior oblique ligament, the POL. This is the one you see better in the coronal projection. Let's go back to it. Flip back over. As most of you are not used to seeing the POL. Got it? It's right there. It's this little structure that lines up with the meniscofemoral ligament. And it travels with the superficial MCL and the back fibers of the TCL, although the back fibers of the TCL are very attritional. It's mostly a mid-coronal plane structure. So when you're in the back, really these are superficial fibers of the MCL, and this is the POL right underneath it. I'll blow it up a little bigger so you can see it. It's hard to see. It's right there. That's the POL. The POL has 3 slips, a superior slip, a central tibial arm, and a distal arm, and these are really hard to sort out. The POL is also known as the ligament of Winslow, not to be confused with the transverse anterior ligament of Winslow that connects the 2 anterior menisci. An important mechanism of stabilization for the posteromedial corner is the break-stop function that keeps the meniscus from wiggling back and forth, especially when you flex your knee, like you're rotating a tire on a car. If you lose that break-stop mechanism, now the meniscus gets rolled by your condyle. It's like taking a rolling pin and rolling it and squishing it backwards. And the meniscus, as a result, thank you, as a result, becomes macerated progressively over time. Shall we take on another case? Let's do it. Now, what happens if you do not operate on a patient with a PCL and an if you do not operate on a patient with a PCL and a posteromedial corner injury? You get anterior medial recurrent instability. So in other words, the tibia is going to start to sublux forward instead of backwards. In ACL deficiency, you're going to have a tibia that goes straight forward. In a patient with a PCL deficient knee and a posteromedial corner injury, you're going to have anterior displacement of the tibia with external rotation. And this will occur even with simple acts like walking. So the PCL is a restraint that can be done without, but if you lose one of the corners, you will have an unstable knee. So the hallmark of a PCL and a medial corner injury is anteromedial recurrent instability. If you've got a lateral corner injury, then it's PLRI, posterolateral recurrent instability. It's a 21-year-old football athlete with medial pain, injured 3 days ago. Got 3 axials for goodness knows what reason. Don't need 3 axials, only need 1. Have an axial T2 fat suppression, have an axial PD fat suppression, more water weighted, pretty water weighted, morphologically weighted. This is a PD without fat suppression. It is not a T1. What should that mean to you? Long TR, short TE, looks T1, but it isn't T1. It means you will miss bone lesions on this series. Do not use this series to look for edema, fractures, tumors, other. Use the true T1 and the PD spur, the one on the right. Do we have a true T1? I think we do in the coronal. We'll get to it. We have an effusion. We're getting faster now. Our ACL, maybe a little swollen interstitially. Our PCL, swollen. How about the back of the knee? Very swollen. The tibial plateau is injured. Let's check out the corners. We know the lateral side because the lateral patellar facet is usually longer. So that's lateral. Not a tremendous amount of swelling in the posterolateral corner. Biceps femoris looks okay. Fibular collateral looks okay. The popliteal portion of the capsule looks okay. The OPL looks fine. In the middle, not so much. The semimembranosus, pretty darn swollen, especially the direct head insertion. How about the tibial collateral ligament? Pretty good. All right, let's put something else up. We've got 3 coronals. We've got places to go like lunch. So that's the next thing that faces us. There's 3 of them. There's a lot of them. Let's scroll. So what do we think the mechanism of injury is here? There's a lot of anterior bone involvement in the tibia. There's not a kissing lesion on the femoral side, so the choices are hyperextension or direct blow from the front. If it's hyperextension, we'd be worried about a knee dislocation, but the ACL is intact. So more likely, direct blow. With a direct blow, we'd be more worried about driving the tibia backwards and rupturing the PCL. That's a classic mechanism for PCL injury. So if you see somebody fall, they're playing Aussie rules football, which is popular in Melbourne, and they go down like this with the toe pointed, and they strike the knee on the ground, and then they get up, they run off, and they come back on, they got a PCL. And then they play 3 more plays, and they say, you know, it doesn't feel right. They go off, and they're done for the day. 2 weeks later, they play again, even with a PCL tear. That's classic. So blow to the front of the tibia with the foot and plantar flexion, or you're driving in your car, you got your knees up, you bang the steering wheel. Or you're in an airplane, so-called aviator injury. So is our PCL intact? No, it's not. We're going to draw a circle. We've got 1 good bundle, 1 bad bundle. Yes, there are 2 bundles of the PCL. So we have a high-grade PCL tear. So our next job with a PCL tear is to decide, is there a fracture at the tibial sulcus of the PCL? No. Doesn't need surgery for that. But it would need surgery if there was a corner injury. So we better check that out. Let's finish our coronals. MCL. Mild superficial swelling. Tibial collateral intact. Meniscofemoral attachments intact. See if we can see the POL. There it is. There's the posterior oblique ligament, the so-called ligament of Winslow, intact. Let's go to the lateral side, fibular collateral. It's fine. Sagun fracture? No. Footprint of the FCL and biceps femoris intact? Yes. Popliteus tendon intact? Yes. We said, though, earlier in our axial assessment that the semimembranosus looks swollen. Better check it out. Time for some sagittals. So here is our severely injured PCL. I would call that high grade. And with PCL injuries, the tibia will sag posteriorly sometimes. So you get what's called the MR sag sign. Instead of it translating forward, it goes back the other way. It goes posterior relative to the femur. I think you might posit that the tibia is a little displaced in the back, but you could argue either way. What about our semimembranosus? Well, the main insertion of the semimembranosus is swollen, isn't it? It should be a nice, thick, black band. It's injured. What about our meniscocapsular reflection? Certainly not nearly as bad as any of the cases you've seen. Is it swollen? Yes. Can we see attachment fibers? Yes. So there's been a capsular sprain, but not a capsular rupture. There's been a posteromedial direct head of semimembranosus injury, but it is not detached. Let's go back now to the capsule, the posteromedial capsule. It's a little wavy, it's a little irregular, it's inconstant. The patient has injured the oblique popliteal component of the posteromedial corner. Now that in itself is not cause for a surgical procedure. You've got to have more than that. You've got to have either separation or you have to have detachment of several of the major bundles of the semimembranosus before you decide to operate to prevent anteromedial recurrent instability. But all of this swelling is a harbinger of a posteromedial corner injury, which often is not commented on. And in a PCL case, it's of critical importance. Let's go over to the lateral side. This time we do not have a mermaid sign. We have a beautiful popliteofibular ligament. We have a beautiful view of our meniscopopliteal upper fascicle. Our lower fascicle is intact. It's a little bit swollen. And we have torn the arcuate. There's the arcuate right there. We have a free arthrogram of the arcuate produced by blood. There's the arcuate, one limb of it. It's kind of shredded looking. The arcuate is a very thin, fibrillated structure, so it is one of the most prone structures to rotatory insult. So we have an arcuate tear, which means we have a low-grade posterolateral corner injury. We have a low to intermediate grade, actually an intermediate grade posteromedial corner injury that involves the posteromedial capsule. This is all capsular tissue. Let me blow it up so you can see exactly what I mean. Straight, 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 wavy, 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 wavy. That's all part of the OPL of the posteromedial corner. So another posteromedial corner injury and a posterolateral corner injury. So the hallmark of a posteromedial corner injury is anteromedial rotational instability, which I attempted to explain to you earlier, and maybe I'll do a better job now. There's excessive anterior translation and external rotation of the medial tibia with respect to the femur. It's also accompanied by medial joint space opening. We talked about the components of the posteromedial corner, the oblique popliteal ligament, which goes around the back, the posterior oblique ligament, which kind of comes around the front and travels with the superficial back portion of the MCL, the posteromedial joint capsule, and the posterior horn of the medial meniscus. We will get to see several of the arms, but not all of them, of the semimembranosus tendon expansion, and you have seen a few of them. You've already seen the pars reflexa and the principal or direct arm, which is the big, thick insertion on the back of the tibia. The main tendon is going to bifurcate into the direct and anterior pars reflexa arms, and the other arms are of lesser importance to you since they're hard to see. The other important components of the semimembranosus corner are the two that I have concentrated on. The POL, the posterior oblique ligament, ligament of Winslow, seen coronally, and the contribution to the posterior medial capsule, the OPL. We have time for one more. That direct head inserts on all kinds of tubercles. They have different names. One of the names given to it is the tuberculum tendinous. I've also heard it called the semituberculum tendinous. I don't think you have to worry about it. It's just a tubercle in the back. Professional hockey player. Not just any professional hockey player. Probably one of the 5 best professional hockey players in the world. The chief complaint is when he pushes off the left leg in a certain position. He experiences a weakness and then a sudden lock, and then the knee gives way. He does have a slightly short medial facet and a longer lateral facet, so mild dysplasia anteriorly. He does have anterior patellofemoral chondromalacia, but so do all athletes. And that doesn't fit at all with his history, which is posterior and medial. Actually, it's posterior, not medial. His effusion is small, but abnormal. I allow 1 by 1 centimeter. He's a young guy. He's in his 20s. He's got a little more fluid than he should have. Let's go to his coronals briefly, even though those are not the star sequences in this case. He's got a great-looking knee for a professional athlete. Menisci, they're good-looking. They're robust. They're black. However, he does have one signal alteration where it should not be, near the lateral meniscus root. Let's go to the sagittal. His ACL's intact, his PCL's intact, his MCL's intact, his fibular collateral's intact, his popliteus is intact. His POL is right there. It's intact. Sagittal. It's a tricky little case. You're dealing with a world-class athlete. If you operate on this person, you better be right. Could cost you $1 million a game. ACL, normal. PCL, normal. Medial meniscus. There's some signal back there, but I inadvertently said he had posteromedial pain. I was wrong. He has posterolateral discomfort and a sudden locking sensation. So there is some swelling here, but he is a professional athlete under constant stress. But his finding is right here. That's the finding. The inferior popliteal meniscal fascicle, which wouldn't bother an old goat like me, who doesn't rotate at 180 radians per second and can't run worth a hoot. It wouldn't bother me at all. But for somebody like this, problem. That is a menisco-popliteal fascicle disruption. And that allowed the meniscus to do this, to twist, and to also be pushed out when his leg was under flexion and he was pushing off that skate. Now, this signal that was on the inside of the meniscus, which is abnormal, was probed, it was sewn, but we believe it wasn't his major problem. It was probably secondary to the meniscus moving in and out, being hypermobile as a result of the loss of the tether of this inferior fascicle. So this is a fascicle injury, an isolated fascicle injury, leading to a secondary meniscal flap tear near the meniscal root, producing inordinate symptoms in a professional athlete. Tough case. I just want to finish off the knee with a final discussion of the posteromedial and lateral corner, and then some miscellaneous disorders of the knee, and then move on to the hip. One of your colleagues came up to me at the break and was asking me about the position of the meniscus and the coronal projection. The meniscus for a younger person is slightly displaced, and the reason for that is because it's lost some of its anchorage. Now, we talked about the loss of anchorage posteriorly and how with the loss of the block stop mechanism, the femur functions as kind of a tractor tire and turns on the meniscus and kind of pushes it back, and that is happening here. One of your colleagues also pointed out that there was some extrusion or displacement of the meniscus in the coronal projection, and at first glance during the break I thought, well, maybe there's a little tear there, but there's not. There is a tear, however, right here, right at the junction of the ligament, the root ligament, and the meniscus root. So that's allowing the meniscus to migrate out medially, and it's the posterior semimembranosus corner injury that's allowing the meniscus to migrate out posteriorly, and this will be worse in knee flexion. The signal that you're seeing here is simply waviness of a hypermobile meniscus due to the loss of its tether at the root, and that is called meniscal flounce. So flounce is really a meniscus free edge that is wavy and is surrounded by a little bit of fluid and a little bit of synovium. If you look at it sagittally, it'll have a smooth edge to it, and you won't see any meniscus inside it. It'll be only on the free edge. So what are you seeing here? You're seeing nothing more than swelling, capsular thickening along the free edge of the meniscus in the coronal plane, being volume averaged as a potential radial or flap tear. The actual tear is here. I've also taken the liberty of doing some labeling for you so that we can finalize our discussion of the posteromedial and lateral corners. So if you would scroll all the way out to Series 11, Image 3, on this case, you see this faint structure going down here. This is the inferior popliteal arm of the semimembranosus. Then there are two direct arms. There's a principal direct arm, which is the main semimembranosus. That's this one. And that one is the one that inserts on the tuberculum tendinus of the posterior tibia. And that one is injured. Then we can see the capsular arm right here. And as we moved more medial, we saw how the capsule was wavy. I'll show that to you in a moment. If you look very carefully, there's a linear structure that reflects back on itself. It makes a little arc right here. That is the anterior arm of the semimembranosus known as the pars reflexa. Now let's go a little bit deeper. And there is the capsular contribution of the semimembranosus to the OPL, which we showed you earlier was wavy. There is another direct arm. It's the non-principal arm. Remember, we got the principal insertion, the principal direct portion of the semimembranosus. Here's the non-principal distal portion of the semimembranosus. So it gets a bit confusing. There are quite a few structures here, and you'll be able to review this again on MRI Online should you decide to do so. And then here is another labeled structure, the posterior oblique ligament as it relates to the posterior superior meniscus at the meniscocapsular junction. And there are several components to the posterior oblique ligament. It has a pretty broad expansion from about the mid-coronal plane arcing back. So let's look at it coronally. Let's go to the front of the knee first in the coronal plane, Series 8, Image 20. And I've marked this low signal structure, which is not the meniscofemoral ligament. It's deep to it. It's the central arm of the POL, the posterior oblique ligament, also known as the ligament of Winslow. Not the transverse meniscal ligament of Winslow, which is found over here, but the ligament of Winslow. Then we've got the superior capsular arm, which sits underneath the superficial portion of the MCL, and the central arm, which sits immediately above the meniscus. The central arm is going to continue around back. This structure is continuous with this structure, which is also part of the POL. So this is POL, this is POL, that's POL, and that is POL. And I have the individual segments of it labeled for you. Going back to the semimembranosus, the main semimembranosus tendon, remember it has 5 reflections itself. One of those reflections is an inferior arm. That inferior arm is really hard to see except in one projection, the coronal. And I'll bet many of you have wondered what this is, the structure coming all the way down like this thin linear structure. That is the long inferior arm of the semimembranosus. That is part of the posteromedial corner. Now let's go to the axial projection. I think I may have some labels on there for you. Maybe not. Oh, yes, I do. So here is, remember there are 2 direct components to the semimembranosus. The important one is the principal direct, the main tendon. So that's this one right here. Right here. Here it is here. In the axial projection, look how much easier it is with heavily water emphasis, proton density, spur, fat suppression, fat set, whatever you want to call it. Look how swollen it is. It is clearly injured at its insertion. Now, as we go down, we see the superficial MCL. Deep to that, traveling with it, is the POL. That little thin linear structure is the POL, the central portion of it. Let's keep going down a little further. And here you see the inferior arm of the semimembranosus right here. So now let's go over to the lateral side. This patient did not have a lot of lateral pathology. Mostly the pathology was located in the arcuate. One of your colleagues was asking me about the wave sign. I've not used that term, but you know, when the arcuate tears like any ligament, it's wavy. So you could use that sign. But these irregular, fibrillated, striated appearing structures that are non-continuous represent areas of arcuate injury or tear. So I'd like to just briefly summarize now the posterolateral corner, which I did not do. And you've already seen this diagram. It is difficult to tease out the arcuate and the sagittal. You just have to assume that when you're lateral, you're seeing the lateral bundle, and when you're medial, you're seeing the medial bundle. The medial bundle is going to have more of an acute course to it. Posteriorly, we see the fibular collateral ligament. It merges with the biceps femoris, but not really. They have separate footprints on the fibular head, which I'll show you in a moment. The arcuate is a condensation of the capsule. It's contiguous with the joint capsule. This posterior coronal view of the knee also shows the attachment of the popliteofibular ligament, which comes from the popliteus tendon to the fibular head. That can be torn at the attachment or somewhere in between. That is the injury that gives rise to the mermaid sign. The arcuate is going to sit posterior or superficial to the popliteus. There's a blown up view of the popliteus tendon. The arcuate sits behind it. The medial bundle of the arcuate has a more oblique course. The lateral bundle has a more vertical course. So when you see them in the sagittal projection, if you see the arcuate as a round structure coming apart, then it's probably the medial bundle. If you see it as a linear structure that's coming apart this way, you're probably looking at the lateral bundle. So that may help you decide which bundle, although it's not really that critical. On the lateral side, in a sagittal projection, we can directly, on FOSS, visualize the fibular collateral ligament. A common mistake is to confuse it with the popliteus tendon. The popliteus hiatus is going to lie over here, antero-inferior to the origin of the FCL. So that should help you be a little bit quicker in your assessment of the posterior lateral corner and the lateral collateral complex. Here's a complex view of the fibular head, summarizing the key structures that it insert on the fibular head. In yellow, we have perhaps the most important of them all, the fibular collateral ligament, which surgeons often refer to with the name lateral collateral ligament, although that's not anatomically proper. Then we've got the two heads, sort of a bifid insertion of the biceps femoris, one in brown, one in red. Together, these are referred to as the conjoint tendon, a misnomer. Then we've got the arcuate ligament. The arcuate ligament is indicated in light blue here, anterior, and behind it, in patients that have it, the fibular-fibellar ligament. If this is big, that's little. If that's big, that's little. And then finally, we have in pink another very important structure that has been overlooked until the last 4 to 5 years, the popliteofibular ligament, which is an important stabilizer and gives rise to the mermaid sign. I've got my axial. I'm going to ignore the patella for now, even though it's not perfectly normal. It's got a little bit of chondromalacia. And I'm going to tap right into the finding that strikes me, which is here, in the anteromedial aspect of the knee. It's an axial T2 Fastman echo 3 millimeters. Let's put up the coronal and the matching sagittal, both water weighted. So here's our posterior medial corner, a little swollen, but otherwise looking pretty good. Until we get to the meniscocapsular attachment. Too fat. Way too fat. Look at the coronal projection. The patient has ruptured the tibial collateral ligament. You cannot rupture the tibial collateral ligament and preserve the superficial layer, so you don't even have to look. It's torn. You cannot tear the deep layer without tearing the superficial layer, so who cares? Let's go deep. Layer number 3, the meniscofemoral ligament, it's torn. So there is a meniscocapsular detachment. And that detachment keeps going on to the back. Let's keep looking. It is still detached. Now, what is that little structure hanging on right there? That is the POL, the posterior oblique ligament of the posteromedial corner, hanging on by a very, very thin thread. But the rest of it, detached. That's a meniscocapsular separation, nearly complete. And that is what all this posteromedial corner swelling is about. The principal direct head of the semimembranosus, swollen but intact. Let's look at another one.
Number 57.
And that one is accompanied by, that one is accompanied by a 3-level tear of the medial collateral ligament. Twisting injury 1 month ago, medial side pain. Patient is 62. I'm going to do a quick review of the axial. These are 3s. Had they been 1s, I would have reconstructed them for you to show you the pathology. Nice view of the posterior capsule, oblique popliteal ligaments, side to side, interconnected, showing the relationship of the posterolateral and medial corners, that they're interrelated. Direct head, principal head of the semimembranosus. Popliteus. All looking pretty good. Let's get to the water-weighted images. I'm not a big fan of T2 imaging for meniscal evaluation, but it does do a very good job at looking at menisco-ligamentous relationships and meniscal position. This meniscus is extruded into the gutter. It's in the paratibial gutter. Patient is not even standing. So this meniscus is essentially non-functional. Let's keep looking at it. This is the lateral meniscus, normal for age. So why did this meniscus slide? Because it has a giant complex flap tear. Now, why is it not a horizontal tear? Let me get my marking pen out. A horizontal tear is horizontal. So if I draw a meniscus, do a better job at drawing, it looks something like this. Whereas if I have a flap tear is like a radial tear. It'll come in from here, and then it'll start to curve and dive down. So it'll dive from superior to inferior. It'll oblique its way through the ligament. So if you look at it from the side, it may look like something like this. It may hit the bottom and come back up. Or it could start over here and hit the bottom and then come back up. And that's what this tear has done. It's come down. It's dove in two directions. It's dove this way. Is that a word? Dove? Divin? Dove? Let's try dove. So it's doven forward. It's doven backward. You can also doven in temple by doing this. And it has bounced down off the bottom and come back off the top. So it's got complexity to it. We know it's unstable because the meniscus is displaced and the tear is huge. So size alone doesn't qualify it as being unstable. But twisting, turning, folding, flapping, separating, extruding, that's unstable. That tear is extruded. That's unstable. That one's going to lock. That one is a candidate for surgery, even though the patient is a little bit older. Let's look at it sagittally and see if there's any other information to be gleaned on the T1 fat-weighted image. Not really. And on the T2 image, we might use this to look at the meniscocapsular attachments or to look for a cyst. He has none. It really doesn't add much to the case. Let's do another one. A huge, unstable flap tear. Instability, displacement, twisting, gapping, extrusion. I often will differentiate extrusion from pseudoextrusion. What do I mean by pseudoextrusion? Well, it's displaced out, but all the attachments are there. They're just stretched. That happens a lot, especially in overweight people. Or true extrusion, when I have a root tear, or I have a posterior corner tear, or I have a complex tear where part of the meniscus is being displaced out. So I have a morphologic defect. Then I use the term extrusion. Otherwise, stretching, pseudoextrusion. That's just how I do it.
Number 60, 060.
But I will qualify it for the clinician. I will say pseudoextrusion due to stretching of the attachments. The meniscus is 50% displaced, or the meniscus is displaced down into the gutter. Most of the time, if it goes down or up, it is an unstable situation with an anatomic morphologic abnormality, like a root tear. Okay. Start out with the axial. This is a well-known American football coach. He's a hard worker. He never takes a day off. His calf is twice normal size. He goes to the emergency room, finally, after pleading from his trainers and doctors. He has the dreaded hospital-based imaging procedure, which leads you down the wrong trail. they do for his swollen calf an ultrasound. And they say he has DVT, deep vein thrombosis. The reason they said that is they couldn't see a vein. Here's his artery. There's his vein. Why couldn't they see the vein? Oh, at some point it probably did have a DVT. It's shrunken into a scarred, small structure. But when you have acute DVT on MRI, you've got a vein filled with blood that's puffy and swollen with swelling around it. No way does he have acute deep vein thrombosis. But they put him on Eliquis for his DVT. And then the next day while he was coaching, his calf got 3 times normal size. So that's when he ended up coming to me. And of course, I'm one of the main doctors. Nobody called me about it. Nobody called the orthopedic surgeon about it. He just went off and got all this stuff done because he didn't want to be taken out of work. He has a severely arthritic knee, and we could spend hours talking about the degree of arthritis that he has. By the way, he jogs. So what's going on? Why is his calf getting bigger? Because on Eliquis, he is bleeding into his Baker's cyst. Let's take a look at the T1. How do we know it's blood? It's got methemoglobin staining in it. They took him back to the hospital before I got the phone call to give him more Eliquis. Fortunately, I got a phone call, and we detoured him into the MRI and figured out very quickly that he never had DVT. He had a ruptured, bursting, bleeding Baker's cyst and an attritional, small popliteal venous system from prior bouts of insult. Nothing new in that category, and the MR solved the case in its entirety. He also has hideous DJD, a ruptured, bleeding Baker's cyst. These are very hard to control. We had to get him off Eliquis very quickly. Otherwise, he could have developed a compartment syndrome, and he was on his way. Next.
Number 64064.
Don't forget to look at that popliteal fossa. Swollen knee, evaluate for meniscus tear. I'm going to go axial. We have a dysplastic patellofemoral articulation. Perhaps that contributes to intra-articular irritation. Irritation could produce synovial hyperplasia, something that looks like this. Hypertrophic synovium that's gray and irregular and beaded. It sometimes even looks like rice bodies. The medial facet is vertical. The lateral facet is horizontal. The medial facet is short. There's a shallow trochlea. We call this a Weiberg 3 patella. And again, perhaps that irritation of grinding has created this synovial problem. But what about these dark areas? They're darker than the synovial-laden areas that are gray. What could it be? A body, a fragment, bone, cartilage, hemosiderin, blood? Let's decide. Let's get 2 different sequences up together. Let's pick something that is heavily water-weighted, like our PD spur, and something heavily fat-weighted, like our T1. And let's find some of those dark areas. They're up a little higher, aren't they? First of all, it's a true T1. What do you think of the effusion? Very proteinaceous or blood-tinged, isn't it? It's not simple fluid. Let's put up the T2. Wow, the T2 is impressive. We don't have a gradient, unfortunately. So can we call this synovium? And the answer is no. Synovium is gray. This is too dark. There's been no trauma. The patient has a swollen knee. It's monoarticular. It's multifocal. In fact, some of it down here is adherent to the front of the femur. It's also anteromedial. Compare it to tissue that is more synovitic, more gray. Synovial hypertrophy, synovial pigmented metaplasia, synovial pigmented metaplasia, and more, multifocal diagnosis, PVNS, with concomitant synovial hyperplasia and patellofemoral dysplasia. Why is MR so important? Not just for the diagnosis of a monoarticular disease that is not necessarily an arthritis but a metaplasia, but because the treatment for this is synovectomy. You have to figure out where to put your ports. There are at least 8 to 10 different ports of entry. And to access these foci for synovial resection, you have to decide where to go based on where the PVNS is. So for surgical planning, MR is queen, king, prince, lady, or duke. Let's do another one. Anteromedial pain for 1 month. Weakness, evaluate for medial meniscus tear. Patient is born in 1951. 66 years of age. Okay, let's start out with our axial. Anteromedial pain. We have a deep ulcer in the apex of the patella. It goes down to the osteochondral plate, this black line, which represents cortex and plate. It's a full-thickness ulcer. It explains her pain, as does the trochlear erosion underneath it. Some trochlear chondromalacia, a little more subtle laterally, not so subtle in the middle, not so subtle medially. Thank goodness it's just that and not a life-threatening problem, like a popliteal artery aneurysm that you might miss because you're focused on her anteromedial pain. So she dies from her aneurysm, but you fix her anterior knee pain. Better look at the popliteal fossa. There she blows. Let's put them up. That's part of your search pattern. There's your aneurysm. So I will give you the patellofemoral disease, and as mentioned, I enjoy looking at the trochlea in the sagittal projection. I get as much or more satisfaction and accuracy from this view as the axial view. Shall we do another? 18-year-old, knee popped in November. He's got persistent pain and swelling. I've got an axial proton density fat suppression, also known as a PD spur, spare, special, fat sat. They all mean the same thing. Long TR, short TE, fat suppression. Slightly different than a stir, although the end effect is similar. Stir used more commonly at lower field. A history of knee popping makes me think about an ACL tear. There's a little swelling in the ACL. Makes me think about a bucket handle tear. Makes me think about another ligamentous rupture. I also get histories of popping in people with acute cartilaginous or bone injuries, especially if they're small. Sounds a little bizarre, but it happens. Wow. Wow, wow, wow. He's only 18. Now, his knee popped in November. It is now September. So it's been almost a year, November of 2016. And we're now in September of 2017. Does that make a lot of sense? Hell no. And he's only 18. So your first instinct is to call this intramedullary cancellous bone microtrabecular injury that's persistent, and you might be right. Perhaps the patient is changing his gait, altered mechanics of weight bearing because he's got something else going on, and he does. He's got a lesion in the tibia. Let's keep looking, shall we? Now you've got a decision to make. Could this lesion be causing all this edema? Could this lesion be causing a pathologic fracture because of alteration in gait? Or could this lesion be completely unrelated and just incidentally detected, and he has a chronic, long-standing, repetitive, microtrabecular, intramedullary, and chondral bone fracture? The last scenario is highly unlikely in an 18-year-old unless he has osteogenesis imperfecta tarda, which is unlikely. Because now you're giving him 3 different diseases. So we either are dealing with edema related to this lesion, primarily, or edema related to trauma from altered mechanics of weight bearing from pain from this lesion. And it's hard to say which is which. But I would posit to you this, that most of the edema on the medial side is related to this lesion. Look at it in the sagittal. It's the eye of the storm. It's Cyclone Tracy. It's Darwin without the alcohol. And the edema is circumscribing in a cyclonic fashion right around our nidus. We said our nidus in an osteoid osteoma should be cloudy. Well, we don't have an X-ray, but it should be gray or dark, not bright like the matrix of cartilage. This is gray or cloudy like osteoid matrix. It'll have a rim of low signal, and it'll oft have extensive edema, and this one does. Now, can I absolutely swear to you that these outer areas of edema are not related to trauma and related to our osteoid osteoma? No, I can't. I don't know the answer to that. But the medial edema is related to this lesion. What do you do with it? Well, you let it burn out. We used to trephine needle biopsy these and remove them. We used to laser them. We used to burn them. One of the experts in the United States is an esteemed pediatric radiologist from Melbourne who emigrated to the U.S. over 20 years ago. And he used to do most of them in the Midwest. A fantastic radiologist named Neil Johnson. We no longer do them because they go away. And it's not a very nice thing to stick a big fat needle in somebody's tibia and extract a piece of bone. It hurts. Osteoid osteoma was described by Jaffe as an osteoblastic tumor composed of osteoid and atypical bone, and he established it as a distinct entity. There is controversy about what causes it, whether it's a tumor or a post-inflammatory reaction or a vascular occlusive event in the Haversian system of bone. 11% of all bone biopsies that come out of people are osteoid osteomas, and that's a crime because they really should just be left alone and left to burn out their course. It's about 13% of all benign tumors, and spine lesions commonly present with painful scoliosis. Those can be really problematic, and occasionally those will have to be trephined out because of the scoliotic complication that they induce. Intra-articular lesions are really difficult, especially in the hip. That is one of the few times when I will consider doing a CT around the pelvis of a younger man or woman. When I have unexplained hip edema and I'm not sure I can detect the nidus on MRI, I go do very thin section, 0.5 millimeter CT with reconstruction, and I frequently find the nidus. The amount of edema is very variable when you have these subcortical intra-articular osteoid osteomas. It can be pronounced or virtually non-existent. It's a tumor of younger individuals. Males predominate about 3 to 1, and it is rare in Black Americans and African Americans. The pain is almost invariably more severe when they're less active, so worse at night. And they are relieved by aspirin and nonsteroidals or Advil, and they are usually managed this way for several years. It usually takes anywhere from 2 to 4 years for these to completely burn out, but usually the pain is controlled within a matter of weeks with nonsteroidals. The typical location is the femur and tibia. This one's in the tibia. They do like the long bone diaphysis. This one is metaphyseal, and when they involve the spine, they usually involve the posterior elements of the spine, similar to the osteoblastoma some of you might have seen in the neuro section of the course that had a secondary aneurysmal bone cyst associated with it. They do like the lumbar region. Okay, let's move on.